Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the Journal September 2025 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Effect of Earlier Age of Tobacco Exposure on Accelerated Biological Aging in Adulthood. It is authored by Dr. Hang Wang and colleagues from Harbin Medical University Cancer Hospital in Harbin, China. 20 years ago, the word exposome was introduced so as to complement and balance the term genome. The exposome was intended as an umbrella term that comprise all those external factors, for example, environmental exposures, lifestyle choices, and internal factors, for example, the microbiome, metabolism, that like the genome and in their own inimitable way served as determinants of health and disease. Assuredly, a major exposome component that causes diverse diseases in adults is tobacco smoke. But does early exposure in life to tobacco smoke exert adverse long-term effects in later years? Why at all address this question by examining such exposures on biological aging in adults followed in the UK Biobank study? Aging was assessed by multiple indices, including telomere length, the frailty index, the homeostatic dysregulation score, the Clemera-Dubal method of determining biological aging, age-related hospitalization, premature death, and life expectancy. Exposure to tobacco smoke was considered when it occurred in utero and when smoking began at ages 5 to 12 years, 13 to 17 years, and 18 years and older. The data demonstrate that, compared with individuals who never smoked, smoking that began at age 5 to 12 years, 13 to 17 years, and 18 years and older were all significantly associated with shorter telomere length, increased biological aging, higher frailty index and homeostatic dysregulation scores, decreased cognitive function, and shorter survival time. After adjusting for possible confounders, exposure to tobacco smoke in utero and at ages 5 to 12 years, 13 to 17 years, and 18 years and older was associated with increased risk of premature total mortality and cardiovascular and cancer mortality. Mediation analysis demonstrated that inflammation as assessed by various markers substantively underpin these associations. This study is novel as it persuasively demonstrates that early exposure to tobacco smoke, including in utero, associates with accelerating aging assessed by multiple indices. This association was mediated by an inflammatory milieu, a finding congruent with the known pathobiology of tobacco smoking. In a larger sense, this important study strikingly illustrates how an inimical component of the exposome, in this case tobacco smoking, can exert distant, long-term adverse effects by promoting accelerating aging in later years. Our first highlight article this month is an original article entitled Association Between Body Mass Index and Age at End-Stage Renal Disease in Patients with Autosomal Dominant Polycystic Kidney Disease in the United States and Japan. It is authored by Dr. Tatsuya Swabe from the Department of Nephrology at Toranomon Hospital, Kanjigaya, and Okinkawa Memorial Institute in Kanagawa and Tokyo, Japan, and colleagues from Mayo Clinic in Rochester, Minnesota, and several other schools and universities in Japan. Excessive caloric intake and obesity increases the risk for chronic kidney disease, CKD. CKD is not a static process, but can progress to end-stage kidney disease, the latter requiring renal replacement therapy. A major objective in managing patients with CKD is implementing therapies that retard the progression of CKD such that end-stage kidney disease is averted or at least delayed. The study by Schwab et al. Examined the age at the initiation of renal replacement therapy and its association with body mass index, BMI, in patients with a specific kidney disease, autosomal dominant polycystic kidney disease, in two populations with different BMIs and dietary habits, one in the United States and in Japan. The U.S. Renal Data System and the Japanese Society for Dialysis Therapy Renal Data Registry were used in the current analysis. The findings demonstrate that Japanese participants compared with U.S. participants at the time of the initiation of renal replacement therapy were approximately 5 years older and exhibited a lower BMI. BMIs in the Japanese and U.S. participants at the time of initiation of renal replacement therapy parallel those of the general population in these countries. Japanese participants were the oldest, followed by Asian Americans, white Americans, and African Americans. Japanese participants had the lowest BMI, followed by Asian Americans, white Americans, and African Americans. The BMI inversely associated with age when renal replacement therapy was initiated, both in the Japanese and American populations, as well as overall. In their discussion, the authors persuasively point out that while the estimated glomerular filtration rate and the use of peritoneal dialysis were both low in Japanese participants, such differences could not significantly account for the older age of the Japanese participants when renal replacement therapy was begun. Interestingly, as reviewed by the authors, the Japanese population compared with the U.S. population generally have lower intake of calories, red meat, high sugar containing foodstuffs, and sodas. These dietary components all promote CKD and its progression. Thus, dietary habits and a lower BMI may delay the progression of autosomal dominant polycystic kidney disease, such that renal replacement therapy is needed at an older age, as occurred in the Japanese participants. Our second highlight article this month is an original article entitled Polypharmacy and Potentially Inappropriate Medications in Adults Greater Than or Equal to 75 Years of Age by Dementia and Frailty Index, the ARIC study. It is authored by Dr. Pamela Lutze from the Division of Epidemiology and Community Health in the School of Public Health at the University of Minnesota and colleagues from several other national universities. A substantive majority of individuals older than 65 years exhibit multimorbidity, the latter comprising 2 or more chronic medical conditions. As multimorbidity increases, so does the number of medications individuals are prescribed. An increasing body of literature has called attention to the risks in older individuals of polypharmacy, that is, the use of 5 or more medications, and hyperpolypharmacy, that is, the use of 10 or more medications. However, relatively deficient in the literature are such analyses involving individuals with dementia or frailty. Using the Community-Based Atherosclerosis Risk in Communities ARIC study, Lutze et al. Assessed the prevalence of polypharmacy, hyperpolypharmacy, and potentially inappropriate medication in adults according to dementia and frailty status. Potentially inappropriate medication was assessed by the modified Bayes criteria developed by the American Geriatric Society. Lucy et al. Demonstrate that in adults approximately 80 years old, polypharmacy was prevalent in 67%, hyperpolypharmacy in 19%, and potentially inappropriate medication in 24%. All such prevalences significantly rose in individuals with dementia, and individuals with frailty had markedly increased risks of polypharmacy and hyperpolypharmacy. In discussing their findings, Lucy et al. Highlight the fact that older individuals, because of older drug metabolism, are more likely to develop drug-drug interactions and adverse drug effects, and that these effects are generally associated with higher rates of hospitalization and mortality. This may be especially true for individuals with frailty, as the latter is characterized by decreased physiologic reserve and resilience. This may be especially true for individuals with frailty, as the latter is characterized by decreased physiologic reserve and resilience to stress. And for a number of reasons, this is also true for individuals with mild cognitive decline and dementia. Individuals with dementia may not understand the rationale for prescribed medications, may not follow their prescribed schedule, and may have insufficient awareness of relevant side effects and the need to report them. Such considerations obligate the involvement of families and caregivers. Moreover, incorrectly dosed or unnecessarily prescribed medications can do harm, especially in such settings. The authors recommend the need for careful and regular evaluation of the dosing of and the need for medications in older individuals, to collaborate with a clinical pharmacist in this regard, and where indicated, to deprescribe inappropriate medications. These considerations are especially important in those with cognitive decline, dementia, and/or frailty. This editorial highlights aging, an ineluctable process that is an overriding determinant of morbidity and mortality and healthcare costs. How aging proceeds is to some extent modifiable, such that not just lifespan, but also healthy aging is enhanced. These articles and this editorial demonstrate how unhealthy aging is caused by early exposure to tobacco smoke, and how age-dependent and disease-dependent progression of autosomal dominant polycystic kidney disease can be retarded by dietary restriction and a lower BMI. Finally, aged individuals develop multimorbidity, which leads to increasing numbers of prescribed medications. The third article draws attention to such concerns as polypharmacy, hyperpolypharmacy, and potentially inappropriate medication in the elderly, especially in the setting of cognitive impairment and/or frailty. You can access these highlights and editor's choice articles free of charge during the entire month of September. We invite you to visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You'll also find links to our social media by clicking the contact link in the gray bar at the top of the home page's drop-down menu to follow us on YouTube, Facebook, and X. Our YouTube channel, you will find full-length author interviews called Insights, and our MCP 60 seconds video article synopses. Another feature of interest on our homepage is a collection of articles that honor the past and look to the future in anticipation of our upcoming 2026 Centennial Celebration. In addition, our website also includes our Mayo Clinic Proceedings issue summary, and Author Insight podcast recordings, which are available from our website on the home page as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.